First, I want also to thanks to the organizing committee for this invitation to be here with you at a wonderful meeting, and many thanks to my dearest and old friend, Professor Majov, with this kind invitation. And I try to emphasize, in fact, the many aspects that Professor Bugra already told you about minimally invasive approach to rectal cancer, of colorectal cancers. There are advantages, also limitations. And we know that by evidence that open surgery will continue to play a prominent role. This is the fact, but also minimally invasive robotic techniques have become more and more accepted. And it's very important for the young surgeon that now this is an essential part of training for colorectal surgery today. Why minimally invasive rectal surgery? Because as we know that in the beginning of 90s, many surgeons don't like to approach for oncological terms minimally invasive approach. After that, after the first randomized control trials, many of surgeons become more and more accepted. But after that, with the latest from the 2015, the first randomized control trials that are showing another way. So this is also controversies. Again, we know the first randomized control trial, Color 2 and Korean, which emphasizes that no inferiority of laparoscopic approach to open. And after that, the other two randomized control trial gave us a hammer in our head. It is laparoscopic worse than open approach, because in this kind of randomized control trial, there are better to perform open in terms of cerebral involvement and incomplete mesorectal excision. It is correct. So again, the question, open, laparoscopic, or robotic approach? Competition is, which is the best? No. Because we know that from the psychological point of view, there are resistance to change. Why that? Mistrust, lack of confidence. Also emotional responses, lack of training, fear of failure, very important, fear of failure, poor communication, and also organization, culture, and norms. So we talk about robotic surgery, because robotic surgery, obvious, developed to overcome the limitation of minimally invasive surgery like laparoscopy and to enhance the capability of open surgery. There are well-known advantages of robotic surgery. Better ergonomics, 7 degrees of freedom, filtering physiological tremor, faster learning curve, very important, faster learning curve, and possibility of dual console for training. But there are also disadvantages, also well known. High acquisition and maintenance cost, material with a limit of uses, lack of tactile sensation, device volume and docking time, and also risk of mechanical failure. But as Professor Mugra already said, the rate for minimally invasive approach for rectal cancer increased. And now, currently, we already saw that is more than 50% in Korea, Netherlands, UK, and Australia. Korea and UK, it's more than 80%. The remaining European countries are uninvestigated and presented lower rates with highest variation ranging 7 to 35%. In Romania today, we are around 20% of minimally invasive surgery, with the mention that for university centers, that percent is higher, around 33%. Also from American data, the use gradually increased each year from 22% in 2008 to 50% in 2020. And this also the paper that already presented Professor Bugra, that robotic approach goes up and close to laparoscopic approach and better than open approach. What about robotic assisted rectal surgery? Is it several advantages, but it is oncologically safe to perform robotic? Of course, we know that the first randomized control trial, rollout trial, and from this, it has failed to show an advantages for the robotic techniques compared with laparoscopic approach. But after that, there are several meta-analyses. This is one of them, with 9 studies included, that shows advantages for robotic approach compared with laparoscopic approach in terms of blood loss, in terms of length of hospital stay, in terms of very important post-operative complication, and in favor of laparoscopic, of course, operative time. What about the other aspect? Because all of us encountered majority of our patients with locally advanced rectal cancer. For these patients, robotic approach seems to be superior to laparoscopic approach due to possibility, much more easier to perform an accurate dissection to preserve all the nerves from superior hypogastric plexus, inferior and pelvic plexus, and to perform a very good lymphadenectomy, very important. This is a short movie regarding very encouraged TATME procedure. Can we perform robotically? Of course. It is much more difficult because you have to make two docking of this robot. But after the first part of the procedure, you can perform much more easier than laparoscopic approach. The dissection, this is the tumor here, and you can perform much more easier due to many greater freedom and to perform more accurate the TATME procedure with the robotic approach. Of course, only 3 arms using for this kind of transanal dissection. I don't want to emphasize that only that robotic approach, even with the absorption of smoke with air seal that we know, it's much more easier to do with the robotic approach than in laparoscopic approach. In terms of operative time, of course, if you use laparoscopic, you can use 2 teams and to short the operative time. But in the end, you can perform resection and a very easier restoring of digestive bowel. This is, again, in advanced rectal cancer, we have many times obliged to perform lateral lymph node dissection. In terms of comparison with open or laparoscopic approach, robotic, it's superior, evident superiority for dissection, and it's very accurate to perform a very good lymphadenectomy. This is another randomized control study published in The Lancet, And the authors suggest that the superiority ability of the robot platform to allow intersphincteric low anteriorization results in a higher rate of sphincter preservation. Very important thing. And we still wait for another randomized controlled trials that are in going from Hong Kong. We are waiting for the results from France and from Spain, and from France with more than 1,300 participants for the next 6 years. And of course, again, artificial intelligence. In that field, of course, artificial intelligence is the most suitable to introduce in robotic procedure. This is the future direction, of course. This is a paper for Royal College of Surgeons. And that commission believes that there are 4 areas of technological developments that will make the greatest impact in the future in surgery. First, minimally invasive. Second, imaging, virtual reality, and augmented reality. Third, big data, genomics, and artificial intelligence. And of course, all that for specialized intervention. This is the future of surgery. So the operating theaters are likely to look different with greater integration of digital. In long term, AI could be used not only to schedule, to request and monitor the environment, but also to make much more easier navigation, like already said. We all see now the 5 level of autonomic, the fully robotic, the fully autonomous robots from Johns Hopkins University that perform now autonomous and intestinal suture. It's the beginning, but I consider that now we are in the phase 2 of autonomy, like means after machine learning, we go further to deep learning. Why that? Because we know that all the procedures performed by robotic are going to a cloud and to machine learning step up forward to deep learning. Digital systems will provide guidance, and theater space will become more flexible and dynamic as equipment will be smaller and lighter. Will be the future. In summary, technology is always good. It is neither angel nor evil. We cannot be afraid of that. And it is up to us to include all the moral and ethical life into this technology. And we should apply them with empathy and compassion for each and every patient. And of course, robotic surgery is one example of such technology for better outcomes of our patients. Thank you.